Good morning, ladies and gentlemen. On behalf of Team DentistChannel.Online, I warmly invite you to the 6th day of the biggest virtual implantology event of 2020. On the onset, I would also like to wish you and your family a very happy Ganesh Chaturthi. May the blessings of Lord Ganesha be with you and your family now and forever. Ladies and gentlemen, we have with us up next a very special speaker all the way from Kolkata. We have with us Dr. Himadri Chakrabarty. Ladies and gentlemen, I know he's a name synonymous in the implantology arena in India and all across the world because of the kind of mentorship, training, and the kind of cases that he's been having since the years of experience he has to his credit. A short introduction about our speaker, Dr. Himadri. Dr. Himadri, Professor of Periodontics, Guru Nanak Institute of Dental Sciences and Research, has finished his Masters in Periodontics in the year 2003 from Dr. R. Ahmed Dental College and Hospital, Kolkata, India. Since then, his focus was concentrated on strict clinical practice of periodontics and implantology. He is trained in several implant systems. He started his implantology training as a certified implantologist from M.A. Rangunwala College of Dental Sciences and Research Center, Pune, India in the year 2004. He continued to be upgraded in implant training under Dr. R.C. Hertel and Dr. Wonderlin from Netherlands. In the year 2006, he completed his training in single piece, that is both mini and conventional compression screws in immediate loading implant system. In the same year, he got his training in most taper hexagon system from Italy. He finished his training in unique BOI, that is the basal osseograded implant system, in the year 2008 under the guidance of Dr. Stephen Ide and Dr. Sigmar Kopp. He has been also trained in a completely new implant trendsetter protocol, that is the immediate post-extraction implant placement and loading and no more sinus lifts in the year 2010 from World, Switzerland. He has lectured all over India on dental implantology and is currently having a clinical experience of placing over thousands of implants of different systems with a plethora of diversities. He has presented an international position paper at Antalya, Turkey in the year 2010. He has completed his fellowship in laser dentistry, postgraduate diploma course from the University of Genoa, Italy. He has completed Masters of Science program from the same university in laser dentistry. He has completed clinical mastership certificate in implantology from Stony Brook School of Dental Medicine, USA, and Dental XP externship certificate program in implantology and an implants prosthodontic master program from Anacapa Dental Art Institute, California, USA. Ladies and gentlemen, presenting to you Dr. Himadri Chakrabarty live.
Thank you, Ruben, for my introduction. And can you see the screen? Is it okay?
Yes, sir.
Okay. So can I go for the presentation? Very warm welcome for everybody online. And it has been a fabulous opportunity for me that the organizers have invited me to talk about this great dental implant expo, which is of its own kind, the first virtual dental implant expo in very crucial time where we are not being able to go more physical, everything is going on virtual. And I'm feeling myself very high on the notes that I'm really presenting on this conference. Without wasting the time, because it's a short presentation of 1 hour, for next 1 hour through, I would like to tell you that what is the hard truth about the soft tissue around the implant. And Ruben has already given my introduction. I don't think it is to be repeated. And the thing is, previously, even 20 years back, the concept was it is the hard tissue that holds the implant for a long period of time, but realizing in the last 2 to 3 decades that eventually it is more important that along with the hard tissue, there must be a harmony of the soft tissue, and then only we're going to have a stabilized implant results for a long time. Now, when we talk about the soft tissue, it means that the soft tissue casing 3-dimensional around the implant, and that soft tissue is very much supporting the bone and underlying implant to maintain stability. There is a famous say that the bone sets the tone, but the tissue is the issue. that is also true. And I pay homage to my guru, Maurice Salama, for saying this for a long period of time. So, because it's a presentation where I cannot see and interact with you, most of my presentation materials are evidence-based, and because today we know that evidence-based is one of the most strong kind of system in which we all enjoy and accept the results, and without evidence everything is very much not enjoyable because they are more anecdotal and more personal opinion based, which are not a great thing in science today. So I would try to give more and more evidences and the procedural flow in the two parts of this presentation. First, I will give evidences of what we have, real evidence, concrete evidence that if you have soft tissue in our hand, if you don't have soft tissue in our hand, what is the difference between this? And then we'll go to the cases in some video formats, in some picture formats, in the flow which we maintain during implants, from extraction of the tooth or to an insular space, to stage one during placement, how we manipulate the tissue, stage two, how we manipulate the tissue, and eventually how we maintain the volume and the quality, both quantitative and the quality with respect to the soft tissue around the implant. Okay, let's get through. Okay, so what is our agenda? The agenda: why do you need soft tissue augmentation surgeries in implant dentistry? What evidence is available in the different techniques to enhance the soft tissue quality and quantity, and how are the procedures performed in the clinic? And we'll try to summarize and do some bit of conclusion. Okay. So, what are the indications of soft tissue in augmentation? Now, we know that we require keratinized mucosal gingiva once it is gone, and which therapeutic means are state of art, and which parameters define whether there is a need for soft tissue optimization, because we understand that soft tissue optimization is very, very much important. So both, as I'm trying to talk to, the quantity and the quality of the soft tissue, both qualitative and the quantitative aspects are more important than any one of them. We need both of them, both the quality and the quantity of tissue. So keratinized mucosa, both in terms of the width as well as the volume, that is the quality or the phenotype of the tissue, both are important. If we don't have, we need to enhance. Why do we enhance? We'll see throughout the presentation. So what are the parameters? The mucosal biotype. Now today we know that we call this phenotype, the width of the keratinized tissue, and the soft tissue volume. So we have three different parameters by which we tell this is the characteristic of a soft tissue, and we need to enhance that to an optimized level to create a kind of a background and an environment in which we'll be able to maintain the implant health in long term. This was first time talked about many years ago, but if you go to this article, the Evans and Chan in 2008, they talked about these three parameters very clearly. Okay. Now, mucosal biotype, the mucosal phenotype. Unfortunately, we require thick biotype with thick phenotype. Everybody is looking at it, but unfortunately, nature is not in our favor. The amount of thick biotype or thick phenotype is only 30%, but thin biotype, where you know there's more of a triangle tooth, and there is 70% of the cases we have only thin biotype. The thin biotype carries more aesthetic risk and more often leads to recessions and visibility of the implants. So probably we need to address this problem. Again, this is by Evans and Chan. Now, keratinized tissue around the implant, when you talk about, can the width of the keratinized mucosa influence the per-implant health? If yes, what is the threshold value? We have different systematic reviews. I have tried to find out the reviews from the available literature into different areas of implantology and periodontics. And we can see there are so many articles from Brito, Chiu, Gabato, Anamila Ortiz, Lean, and Winston, which all of them talk about that is the keratinized mucosa indispensable to maintain the peri-implant health? And they say yes. Significance of the width of keratinized tissue or mucosa around the implant is of paramount importance. Now, can the width of the keratinized mucosa influence the peri-implant health, relying more on the recent studies? Yes. If yes, what are the threshold values? The threshold values were considered at one point of time, especially for the tooth, were 2 millimeters, but our goal is to achieve 3 millimeters. Now, from the concept of Thomas Linkevicius, when we talk about tissue zero bone loss concept, minimum 3 millimeter, best is 4 millimeter. But our goal is to at least attain 3 millimeter rather than the so-called gold standard, which has been for the last 4 decades, about around the 2 millimeters, has to be changed to 3 millimeters. Okay. Now, how much tissue, soft tissue volume do you need from a biology point of view? Again, an important consideration. If the hard tissue augmentation is sufficient in the aesthetic zone, how much does the soft tissue augmentation contribute to the final volume? Let's take out, because we know our weight, we know it's 3 millimeter, but how much volume is required and how much soft tissue we need for aesthetic purpose. Now, biological soft tissue thickness, let's come to these evidences. Our very recent evidences are from this group of people, Ali Aklali and Anna Erickson, that has been published in 2016 Clinical Oral Implant Research. What is the effect of soft tissue thickness on crestal bone loss around dental implants? A systematic review. The aim of the study was to determine whether soft tissue biotype or phenotype at implant placement has an influence on crestal bone loss at 1 year after implant loading or not. So, in this systematic review, they have taken a huge number of citations, 2,944 citations, 6 studies and test control trials made the inclusion criteria. 4 of the 6 individual studies that compared thin versus thick phenotype. And from these citations, it has been found that significantly higher crestal bone loss has been reported in thin biotype. So we know today that we require thick biotype, 3 millimeter or more. We cannot stick to 2 millimeters once again. And no threshold value could be determined based on meta-analysis. But again, I'm talking about that when you talk about soft tissue volume around the implants, we have to stick to certain amount, and you have to know how much is that. But again, considering 3-dimensionally, because you have talked about weight, 3 millimeter. Again, 3 millimeter is the volume of the tissue which is safe to protect the implant to get exposed, or the soft tissue position, and or the implant visibility through the soft tissue. Now the next question is, the hard tissue augmentation sufficient in the aesthetic zone? We have these evidences from 2013. One evidence at least I could find out by Cosine and De Bruin, the soft tissue preservation and peak aesthetics around single implants restoration in 1 year perspective study. The aims of the study was to document soft tissue aspects using a specific protocol for immediate implant treatment following the single tooth removal, and to evaluate whether this protocol allows preservation of the pink aesthetics or not. 22 patients with a thick gingival biotype and an intact buccal upon extraction of a single tooth in the aesthetic zone have been chosen from 1.5 to 2.5. That is the region from first premolar to first premolar, second premolar to second premolar, and first and the second quarter. And flapless extraction and implant surgery and socket grafting, immediate non-occlusal loading with screw retained provisional crown and replacement by permanent crown has been done in 6 months. So we have a follow period from 0 months, then the day 1, 3 months, 6 months, and then T4 is 12 months. So we can understand at 3 months, 5 cases demonstrated major alveolar process remodeling and 2 advanced mid-facial recession. Hence, the slight initial decline in the pink aesthetic score, which is PACE, is observed in 3 months. Of all 7 cases treated with subepithelial connective tissue graft resulted in a steady improvement of pink aesthetic score. The conclusion is preservation of pink aesthetics is possible following immediate implants. However, to achieve that, a connective tissue graft may be necessary in about 33% of the patient, and the major alveolar process remodeling is the main reason for the additional treatment. This is again by the same article by Cosine et al. In 2013. What is the conclusion? The conclusion is preservation of pink aesthetics is possible following immediate implants. However, to achieve that, subcutaneous tissue is necessary, and these outcomes demonstrate the necessity of subcutaneous graft in a single implant case in aesthetic zone, even in a multiple implant case in aesthetic zone, and are supported by 2 more studies, that is by Joseph Kahn and Cornellini in 2009. Better aesthetics, high papillae score, and high mid-facial lines with subcutaneous connective tissue graft of subepithelial connective tissue graft compared to the site without connective tissue grafts. Now, next question is, how much does soft tissue augmentation contribute to the final volume? What are the evidences we have? Contribution to soft tissue to the final volume. The evidences we have is in a fantastic article by this great group from ITI, that is Schneider, Uli Grunder, Ender, and Christopher Hamal and Zhang, which is a volume gain in the stability of the peri-implant tissue following bone and soft tissue augmentation in 1 year result from prospective cohort study. The aim of the study is to evaluate the volume changes of the buccal aspect of the implant site, and which has been, you can understand that, which has been already, if you look at this picture, which has already been augmented from the point of view of bone and given some epithelial membrane with tags, and we are following after 6 months, then 1 month with the soft tissue augmentation, 2 months, and then following by 12 months. 16 patients with a missing tooth in the aesthetic zone. Analysis of volume changes due to hard and soft tissue augmentation surgeries we are doing in this case, and you can understand the results that when we are doing an SCTG, 57% of the volume gain has been formed only by the hard tissue. But when you are doing SCTG, okay, because now it has dropped down to 43% at 1 month without subepithelial connective tissue graft. When you're grafted, in 12 months, you can see there is a volume change. -4 means it has enhanced, it's achieved 100%. Not only it has enhanced 4% above the original volume. So it's a great role of maintaining the volume of the tissue, buccally at least, for the aesthetic zone when we're combining hard tissue along with the soft tissue. And the hard tissue and the soft tissue grafting were effective in augmenting peri-implant sites. This is a conclusion: to maintain the volume that remains stable for a high degree within at least 1 year after crown insertion. The GBR procedure contributed slightly more than to overall volume gain than the soft tissue grafting. So we have also compartmentalized how to differentiate between, and GBR procedure is of course required, but soft tissue grafting, because you can see only with the GBR we have not been able to gain soft tissue. Without doing a soft tissue grafting, we're not being able to gain amount of volume. Now the next question is, how much soft tissue do you need for aesthetic purpose? As I've told you, the effect of full ceramic, this is an article by Zhang, Karasat, Satara, and Christopher Hamal, again by the ITA group in 2008, that the effect of full ceramic restoration in the person infused to metal restoration is on marginal soft tissue aesthetics. It's an RCT. The aim of this study is to evaluate the influence of the abutment material and the soft tissue thickness on the aesthetic outcome. And it has been a 30 patients study with 2 groups of 15 each. One group is from all ceramic and another one from metal ceramic. Soft tissue augmentation was performed in both the cases, and in case there was a less than 2 mm of the peri-implant soft tissue thickness was there, they have done the soft tissue augmentation in this case. And the color measurement they have tried to do with at the implant site and in the contralateral natural tooth. So this is gamma E, okay, and which is tooth minus delta E, which is tooth minus implant. We have tried to do a spectroscopic analysis, a spectral shade color analysis, and you can see the results here that with graft, okay, we have non-significant change in both this, because that means the grafted side, which is soft tissue grafted side, shows the equal amount of color, the quality of the color from value, chroma, brilliance, at the site of contralateral natural tooth site, which is maintained with a tooth. But if you don't have a graft, there is significant change in color. So the change in color at the initial stage says in long term, because of some bit of bone might be lost, you can have a show of the implant color through the tissue if you have not grafted. And there is a change in color perception, both in terms of value and chroma with respect to the contralateral natural tooth side. Thickening of the mucosa by soft tissue augmentation reduce the color differences, that is delta E, between the natural tooth and the implant, independent of the chosen reconstruction material. So you can understand whatever the reconstruction material in terms of bone we can have xenograft, we can have auto-xeno combination, we can have sandwich graft, but unless you have done a soft tissue augmentation, the change in the color, the reduced difference in the color is not reduced, it's more enhanced. So the threshold value of 2 mm is further corroborated by the variety of the clinical and the in vitro experiment. We have different studies with us: Zhang et al. in 2007, Van Brakel in 2011, Kuma in 2015, and we can understand that mucosal thickness more than 2 millimeters. That's why I'm saying three-dimensionally, our target is to achieve somewhere 3 millimeters or more. No statistical significance. If it is more than 2 millimeters, which is perceptibly 3 millimeters or more, no statistical significant color differences can be found between the various reconstructive materials. That means that if we have, in both the situations, in all-ceramic and the PFM, if we have enough volume of soft tissue, which is more than 2 millimeters, perceptibly 3 millimeters or more, we don't have any color difference between the natural tooth side as well as the extracted and implanted side. Now, what are the indications of soft tissue augmentation? We have a fantastic study that has been published in around 2000, in 2014 by Thomas, Mullerman, and Zhang. A thick soft tissue is desired to minimize the risk of recession, and a minimal amount of 2 millimeter keratinized tissue may be favorable. But again, re-emphasizing, our target is to maintain 3 millimeter or more, because you never know that the bond type or the phenotype, because you couldn't change the phenotype, you can only boost it. That has got also a natural inherent shrinkage potential in long term, maybe 1.5, 2 or 3 years. Maybe sometimes, I don't have the case right now. There are evidences that in long term, probably you need to repeat after 7, 8, or even 10 years, you might have to repeat to volume the soft, boost the volume of the soft tissue to bring it back to original form of stability, which you have achieved after 6 months after doing this soft tissue volume augmentation. Aesthetically, the soft tissue thickness on the buccal side should be bare minimum 2 millimeter. Okay, but again, our target is 3 millimeter or more. Okay. Now, soft tissue management in the aesthetic zone, the most important part. What are the agenda we have? Do you need soft tissue augmentation surgeries in implant dentistry? Yes, we have already proved that. What evidence is available for the different techniques to enhance soft tissue quality and quantity, and how are these procedures performed in the clinic? Okay. So let's come to the systematic review. Let's try to find out more systematic review, which are concrete evidences, and the efficacy of soft tissue augmentation around dental implants and in partially dentalized area. Systematic review. Again, I've talked to about 2014 by Thomas, Himadri, and the ITA group. Again, by ITA group by Christopher Himadri and Thomas. Systematic review assessing the soft tissue augmentation techniques that has been published in clinical oral implantology research in 2009. The current techniques are the autogenous soft tissue grafts, which is qualitative optimization and increasing width of the keratinized tissue. So most of the times when we talk about increasing the width of the keratinized tissue, we are not talking about volume. Our first and foremost, and probably the only choice, the best choice, is a free epithelizer or free gingival graft. And these are proved by so many articles, by Sullivan way back in 1968, Egley in 75, Ratzak in 1979, Moorman in 82. So we know that when we have to work with the width of the keratinized tissue, our gold standard still today is a free gingival graft. There are so many biomaterials available in the market, but again, like different kind of dermis materials, lipoderm, alloderm, and so on and so forth. But we know for an open tissue healing, which happens in the width of keratinized tissue, mostly for the keratinized tissue when we are augmenting around the implant and the tooth, and mostly when we're working in minimal keratinized tissue, especially in a single tooth situation or two teeth situation, when we need to do a partial thickness or full thickness or an all-leg graft. For open healing, a free gingival or a free epithelial graft is still the gold standard. Okay, we'll come to the procedures. So timing of the implant dentistry is very, very important. What do you need to do about this? The first appointment, the patient comes prior to extraction. Then we have pre-operative situations, and now usually the original idea of placing implants with a buccal defect was, if we don't have original buccal bone, we have missing buccal plate. At one point of time, we used to say no buccal bone, no immediate implants. Okay, because that needs your higher skill, because you need to do a GBR, probably a simultaneous subcutaneous connective tissue graft, but we don't have the tissue to close because after extraction is an open socket. And if it's an open socket, it is really, really difficult to close that because we don't have tissue. So in most of the situations, even 10 years back, our preference, first and foremost preference, was to do an immediate an extraction, and they bring down and leave this socket to heal for at least next 4 weeks, so that we can naturally gain some bit of soft tissue for the closure of the socket, and then we used to open up and do early placement or regrafted the site with the bone materials, mostly materials combined. If you require faster healing potential, probably a 50-50 graft between xenograft or a high quality hydroxyapatite like made bone, and along with your autogenous graft, and to close the tooth, and we come back, or we place simultaneous implant, and you can do GBR at that point of time. And sometimes we do soft tissue augmentation at the same time. Maybe at the second stage, we can do the soft tissue procedures as well. So prior to insertion of the final reconstruction, our both hard and soft tissue should be clear. I will give you a flow chart. How do we do it? So in the next some slides, and then everything will be clarified. So clinical procedure, preparation of the further frigidable graft, preparation of the recipient side. You know, most of the time we prepare it partial thickness, okay, especially for implant, yes, 100% almost partial thickness, and then harvesting the graft from the palate, from the donor side, mostly because free epithelialized graft we take mostly from the palate, and augmentation and stabilizing with suture. This is a classical technique. Now this is one case. You can see there is hardly any soft tissue here. This is around the tooth. I'll show you around the implant also in the video. Followed by this, we have prepared the surface. Okay, we have sutured the recipient area, the flap which we have separated from the base and the length into the periosteum into the base, and then we have harvested the soft tissue, free epithelial tissue from the palate, and then we have taken out the excess of the fat material from underneath. We have stabilized this area by keeping at least 2 mm gap from the area of suturing where we have done the basic sutures, and then we have stabilized this graft. Okay, and you see this is 3 weeks healing, and the site has 3 weeks. The palatal site from where the graft has been taken, that's also healed. Now nowadays there are so many techniques for stabilization. There is something called tissue tack or gingival tack that is also available, but the results are not that great promising. A suture is still the gold standard. You can use these tacks, but if it is a very long tissue, it is applicable. For a small amount of tissue, when it's a single tooth defect, probably the tacks are not the best kind of things, because if you give tack into a tissue, what you are doing, because the pressure of the tack, the initial vascular supply or the plasmatic circulation, as we see, get hampered. So for a long tissue area, tacks are fine, but for a short area, for a single tooth area, tacks are not great. Sutures are still the gold standard, and you can see the healing potential. The only problem, you can see that from that same area of the tooth, because this tooth was not there, it is an artificially placed tooth which is bonded. Now you can see so much of the volume gain on the left side, which was like this before we started. The only problem about this tissue, we know, I'm going to come to talk about. Now let's see, this is our implant, this video. Let's see this video. Now this implant, you can see, has been placed 8 years back, and now there is a recession, okay? And we don't have enough keratinized tissue. Unfortunately, this keratinized tissue width was not been augmented at the very first place, and now we have got some bit of recession. You can see the implant trace. So probably we need to do, not probably, certainly we need to do a free gingival graft or a free epithelial graft to enhance the width of the keratinized tissue, so that the pull from the vestibular mucosa beyond the mucogingival junction is reduced. So we have taken out this tissue, the partial thickness flap, and now we are attaching the rest of the tissue to the base with the periosteum. That's why I was talking about. So at the base, the periosteum, with the periosteum, we have sutured this. Now we have prepared the bed. This bed is prepared with a partial thickness way. Most of the times in the implant, we never take this full thickness. Though around the tooth, sometimes we take full thickness, but around the implants, we hardly do any time a full thickness. So we do a partial thickness. Now we have to understand, even if we require a 2 or 3 mm tissue, because the graft will shrink in long run, we need to take a larger graft, at least 2.5 times in width than the final graft volume what you're requiring. So at least if we are requiring 3 millimeter width of the keratinous tissue, so it's around 7 millimeter, 7.5 millimeter of tissue width we require. So now we are taking it from the palate. Okay, that's fine. So we have taken it from the palate, taking the partial thickness way, and we're raising the graft from the bed. Fine. So we have delineated the graft, and now we are doing sharp dissection from the base. We have to keep in maintenance that the graft width should not be too much or too less. It should be around 1.5 to 2 millimeter. Now in this graft, if we have already on the underside, we have some bit of fat with this, we will have to excise this fat, because this fat is permeable to the vascular fluid, so the plasmatic circulation initially will be hampered, and now we are placing it here. Now we need to secure this with suture. Again, I told you that we can use tissue tags in this situation because it's a large graft, but most of the time the problems are that again the initial plasmatic circulation has been hampered, so suturing is the best method to do this. Okay, so we are suturing this and stabilizing. This suture has to be stabilized very well, and this is we require suture which is stabilizing the sides of the graft, as well as we require external sutures on the top so that we can stabilize the graft towards the bed. Okay, so this is around the tooth. Now this area we have increased the keratinized tissue in terms of width. Now to cover this area, probably we need to do a connective tissue graft as well. So we need two different kinds of surgery, maybe in a gap of 6 weeks to 10 weeks. Now keratinized tissue, we have 28 results, 9 studies around implant, and apically positioned flap alone is successful. I'll show you one case where apically positioned flap can only be done but the problem is for doing an apically positioning flap, we require a larger area. It's not a 1 or 2 teeth, maybe 3-4 contiguous teeth are missing, and then we are enhancing. In that situation, we have enough tissue to handle, and we can apically position. I will show you a case afterwards. In addition to that autogenous tissue, significantly the width of keratinized tissue around 2.3 to 3.3 millimeter. Again, I'm telling you, for tooth, 2 millimeter is okay. For 3 millimeter is the bare minimum we require around the implants. Okay. Now, what is the long-term stability of this autogenous tissue grafting? So we have different studies. You can see big follow-up periods from 2 years to 1 to 4 years. Then we have 4 years. This is 8 years. This is 7 years. Okay, and around 7 years. This is a study by Dorfman, Hangoski, Bisada, Dorfman, and Kennedy in different years from 80s to 1985. And FGG dimensions range between the 40 to 50% up to 8 years. So again, I'm talking about that whatever you have, it will shrink, no problem. That's why you need to overcompensate by taking a larger chunk of graft. But you can understand that even 50% of the keratinized tissue width is maintained up to 8 years. That's why, because it shrinks, we need to take the double or 2.5 times the original width of the tissue which you are aiming at, to have a stabilization for nearly for next 8 to 10 years. Now, quantitative optimization and augmentation of soft tissue volume is our next target. We have already dealt with soft tissue width, keratinized tissue width. Our next target is to do subepithelial connective tissue graft to increase the volume. We have again different studies by Sullivan, Egli, Reisesek, Morman, Miller, that if we increase the volume, if we boost the volume, we have more stability. Okay, so the timing is mostly during healing phase. I'm telling you that during placement of implant, along with the GBR, you can simultaneously do, but it becomes a little bit cumbersome, because in GBR cases, most of the time you need to advance the tissue to have a watertight closure, and this watertight closure has to be passive as well. So by placing an implant, placing a connective tissue graft subepithelial, our passivity of the closure is always a little bit hampered. So it is the best thing is to do during the healing phase, and either during stage 2 or after simultaneously with the stage 2. but remember, it is prior to insertion. So what are the clinical procedures of the classic flap? Preparation of the recipient site. Most of the times we will do with a pouching technique or a tunnel technique. Harvesting the autogenous tissue from the donor site. Augmentation and suturing at the recipient site, and suturing the donor site. This is the form. So you can understand that when you augmented this volume, the original volume was somewhere here, and we have been able to augment this to this. This is over-engineering. This is good because in long term, even if the tissue shrinks, it will come down to the volume which was originally there before extraction, and the stability of soft and hard tissue around the implant in a long term will also be there. Okay, so this is one side where we have developed soft tissue before placement of an implant, and now you can see when we place the implant, and by tunneling, okay, this is some tunnel blades, micro blades, and this is the donor site preparation. We have augmented the tissue from here. This is a single incision technique, and this is the solid core of connective tissue that we have harvested from the palate. We can do it from also from our tuberosity zone. If it is the third molar is missing in this case, you can take it from tuberosity. Tuberosity gives a very solid and very good quality of the connective tissue, but it requires a little bit separate training. Probably all of us are not very much trained in tuberosity graft, but again, I'm telling you, there are international proponents who are doing tuberosity grafts on a regular basis, and they're fantastic. Look at this soft tissue volume. It's more than 10 millimeter in length, and the width is around 7 millimeter. We are going to put it in. We'll put it in under the flap, and then go for a flap closure. And before that, remember, you need to stabilize this soft tissue connective tissue graft with a palatal suture, and then we are stabilizing the overlying flap into the area. You can see the immediate volume gain into the area. You can see the immediate, this is EPTF suture, this is immediate volume gain. And 3 studies in the tooth by the statistically significant greater gain in soft tissue volume was observed by subepithelial connective tissue graft compared to controls, where the grafting has not been done. And the gain is somewhere in between 1.72 to 3.2 millimeter. This is the Tomato by 2 different articles in 2009 and 2014. And autogenous soft tissue grafts rendered an increase in soft tissue thickness and better aesthetics compared to non-grafted sites. Now, these are the 2 soft tissue grafting techniques, soft tissue harvesting techniques from the palate. Okay, I have placed them together. Okay, one in the left down, one in the right upper. So first one incision has been done. In this case, this area will be pouched. Now look at this. We are doing this. This is a single incision technique. Okay, so we have done a single incision technique here on the lower left here, and we are harvesting the connective tissue through the single incision. Okay, and now on the right you can see we are creating a pouch by either a 15C or a microblade, ophthalmic microblade like Crescent. And okay, this is a Patalin's knife. So we are creating a pouch which will help to receive, because this pouch will receive the connective tissue. We are not going to raise the flap. And now what we are doing the suture from apical area to grab this connective tissue. Okay, now when we grab the connective tissue on the left side, please look at it, that the procedure of connective tissue is being taken. We grab the connective tissue and we are inserting it. This technique is called lassoing technique, because this is like lassoing a wild animal. And with the pull of this suture material, we can introduce this connective tissue. Otherwise, it's very difficult. Now it's stabilizing into the apical area. Please look into the left side picture where we're harvesting the connective tissue simultaneously. So I have placed 2 of these slides together. Okay, 2 of the videos together. So this is the left side we are harvesting. Now this is a single incision technique. Okay. Now look at this. We have, after this has to be done. Okay. So you can see the immediate change in the volume. Left side. Okay. So we are stopping this video. Let's concentrate. First, we have given a 90-degree incision into the bone. Then we have separated this tissue, and now we are doing a dissection, sharp dissection from the underneath of the flap raised or the envelope raised to harvest this connective tissue. That connective tissue has already been will be placed like here, as I've showed you. First, I'm showing you how to do this harvest of connective tissue first. Okay. So it's a little bit tedious procedure. So let's check out the video a little bit first. And with the soft tissue section and cutting the sides. We have cutting the sides. We have taken out the soft tissue. Now we will suture this area. Now some of the people prefer to give some bit of gel kind of a thing, or a gelatin foam, or even PRF cloths out here. So we have harvested the soft tissue, and once you have harvested the soft tissue from the area, I'm just once again showing you that how to do it. We are taking the soft tissue, lassoing it down inside the pouch, and we are pulling this lasso tank and stabilizing this. So this is a no flap procedure. This is like a pouch procedure, but we have been able to augment the soft tissue immediately. Okay, and you can see the immediate increase in volume by 2.5 to 3 millimeters. And now when you see the apical view, you can understand there is an enhancement of the soft tissue. You can understand this was the original level, and now it is enhanced. It is ballooned, and we have boosted the soft tissue volume. Okay. Now, what are the long-term stability of this as well? So we have got a fantastic study by San Martin and Christopher Hammerlagen by the FA group in 2016. The soft tissue stability and the volumetric changes of Pontic sites with or without soft tissue grafting, and retrospective study of 5-year follow. The aim of the study was to evaluate the volumetric changes in Pontic sites with or without soft tissue grafting during the observation period of 5 years. The materials and methods of soft tissue grafting prior to the start of the reconstructive phase, and the soft tissue grafting prior to the start of the reconstructive phase, which has been conditioned with the provisionals and the insertion. You can see this is a volume defect we have. We have augmented that with the soft tissue. Okay. Okay. And now on the right, you can understand, you see the volume defect. This is only soft tissue augmentation. There is no hard tissue augmentation here. You can understand there is substantial volume boosting in this situation. And when you place the Pontic and we have sculpted with the temporary restoration, temporary prosthesis, how beautiful these final results are. Okay. And soft tissue conditioning, the provisional, is a 5-year follow-up. You can understand that when you have boosted, even after 5 years, there is hardly any change in volume. But if you don't do this soft tissue augmentation, after 5 years, you will see there is at least 30 to 50% collapse of the volume. Okay. So results, when you see the results after observational period of 5 years, Pontic sites grafted with subepithelial connective tissue graft show higher dimensional stability, demonstrating that soft tissue augmentation can remain stable. Augmentation in terms of volumetric augmentation of connective tissue, it's a stable and long term. When using autogenous tissue, which is gold standard, I will show you which is biomaterial also used. The greatest disadvantage due to the second surgical site. This is the problem, that we need to have a second surgical site, and donor side responsible for some bit of bleeding, some bit of swelling. This is by Griffin and Soiley. But the thing is, this tissue is still the gold standard. But we have some bit of, you can understand, you look at this volume of the gain of the tissue. Now, this is one case. Let's start clinically. That we are starting clinical cases. This is the first case where we cannot place implant with the old protocol because we don't have any buccal bone. So what we are doing here, so we are augmenting this both with the hard and soft tissue, and with the soft tissue we would try to maintain a sill for socket. Now we are placing some bit of bone. If you require a long-term bone, you can place some bit of xenograft like BioOS or Botis material like Mineros or Cerabone, or you can place, if you require a faster one, some faster resorbing hydroxyapatite, true bone builders like Medbone products. Okay. Now this is the soft tissue. We have taken the graft. Now this is again can be done along with the the simultaneous placement. One of my very good friends, Dr. Snezana Paul, she does fantastically a procedure called AMI band. She takes pedicle graft from the palate and covers, after placing the implants, after doing a GBR simultaneously. But here we are maintaining the socket volume only by pressing the graft as well as putting the soft tissue, the buccal pouch. Okay, and this soft tissue will maintain the seal and will segregate this area to build a bone as well as create volume. Okay, and maybe after 3 to 4 months or maybe 6 months, we will come back and reopen the socket, and still we might require a bit of GBR, again a second soft tissue augmentation. But this soft tissue creates two things. Number one, it is increasing the boost of the volume as well as creating the soft tissue scale. Now let's come to the next phase. Okay, sorry, next one. Now, now we are talking about soft tissue management. First, we have seen that when we have extracted, but we couldn't place implant because there is a buccal defect. Next, we are moving on to soft tissue management during implant placement. Non-submerged implants, preferably as they do not require a second stage surgery because the access of the implant maintained in the above soft tissue. Boozer et al. In 1990 said that osseointegration showed high predictability in one stage non-submerged surgical protocol. This is referred to the elimination of the subgingival implant connection. And soft tissue management in delayed placement, if we are doing, we have a protocol during mucoperiosteal flap. We know the classical vestibular procedure. I'm not going to do this, but we are going to talk about preservative interproximal papilla preservation. This is very important. It favors aesthetic because the preservation of the papilla stabilizes the adjacent margin of the implant supported prosthesis. So our maintenance of papilla is very, very important. Now, even if we are doing simultaneous extraction and placement, we have fantastic methodologies nowadays where you can preserve this papilla, where we are doing from dual zone grafting, because I cannot discuss this detail here, from dual zone grafting to PET, that is partial extraction therapy socket shield, where we're keeping some part of the labial part of the tooth intact so that the bone is falsified, that the tooth is there, and we have tooth is there, and we have a papilla maintenance in long term very well. But here we are talking about when you're doing a flat procedure, we are not doing a simultaneous implant, we are doing a delayed placement, that we will preserve the interproximal papilla. I will show you a picture. Look at this. We have placed the implant, but to preserve this papilla, because this papilla is like gold mine. If you lose this, it's very, very difficult to gain. Even after best of the procedures, we lose some bit of papilla. We know the Tarno's principle. I'm not going to detail of this because that is not the thing that has to be discussed right now. But here is the papilla preservating incision. Then we are widening after we go to papilla to raise the flap, and then we do a closure after placement of implant, but we maintain the papilla as well. Okay. Soft tissue management in immediate implant placement, introduced by Nemkovsky in 2000, achieving primary closure on the top of the immediate implant without modifying or altering the buccal contour of the keratinous tissue. A palatal pedicle flap is rotated towards the buccal mucosa to cover the socket orifice if we cannot do immediate replacement or immediate prosthesis. Okay, so let's see. This is a procedure called roll technique with implant placement. How we can enhance. This is not an immediate placement case, it's a delayed placement case. This is what I talked about. Now look at this. How we are designing our flap. We are not taking a mid-crestal flap or mid-crestal incision. We are doing a little palatal or paracrestal incision. We are doing palatally here. Okay. So we are doing two verticals with one palatal joining line, and we are going to raise this flap. Okay, so that we can utilize some bit of palatal tissue. Okay, it's a beveled incision. We can take some bit of connective tissue pedicle as like a modified palatal flap, modified roll flap by Holmes and Wong, and we will be taking that along with the flap that has been raised buccally. Okay, so we are doing one palatal incision first, and then we are undermining the palatal incision to take a connective tissue collar. And now, after raising the flap, we are going to place the implant. I'm not making a video through. And now what we're doing, that we are closing this soft tissue like this. We are buccally taking this, and this tissue which is excess, we are rolling inside to boost the volume. This is simultaneous technique, and like a free connective tissue, it is attached connective tissue. We are doing a reverse lasso and bringing it inside. Okay, and now we have boosted the buccal volume of the soft tissue by suturing it down. Okay, so this is palatary rotated flap as I talked about. Now if you have placed the simultaneous implant, you have palatally rotated this from a palatal graft we have taken, but this is a pedicle flap, rotated flap, which is created in the palatal side but still having the vascular supply maintained on the palatal side, and we are rotating it and putting in the buccal pouch. It is creating two things simultaneously. One, it is covering the open socket, and it is boosting the buccal volume of the tissue. So creating adequate keratinized tissue around implants. We know about the onlay grafting. We're talking about, I've shown you the FGG here. We are doing an onlay grafting on the top of this. We're stabilizing with external sutures. The drawbacks I've already talked. The problem is the color and the texture mismatch between the graft and the surrounding tissue, because you are taking from the palate. It is not exactly fitting. The problem is initial, if there's graft stability is not great, there will be hematoma formation and the graft shrinkage of approximately 30%. So we have to be very, very cautious about putting this graft and stabilizing the graft very, very well. Okay, this is another situation. Sorry, this is another situation where we can create this graft, as I'm talking about, that this is by apically repositioning flap, but we need a longer span of the missing area. Without doing a graft, we can utilize the palatal tissue to repositioning this apically. Let's see. It's a partial thickness flap with raise, giving a paracrystal incision. The implant is already placed, but we don't have enough with the tissue, and here we don't have enough keratinized tissue. So we're raising a partial thickness flap. Okay, this is a black sandal, reverse black sandal. And this is an implant site. Okay, sorry, implant site from which GVR has been done, screw has been taken out. This is the implant area. Seeing this, now we have attached the healing abutment, and now for the palatal tissue, we have apically positioned buccally to fix it. Okay, and you can see that the palatal tissue has, because it has transformed and it has come to the buccal side, it is now giving a fantastic width of the connective of the keratinized tissue in the long run. Okay, so you need to stabilize this with the vertical sutures, vertical incision being stabilized with the periosteum, and then suturing the flap. So soft tissue management at the time of the abutment connection. Two basic surgical protocols for the exposed implant: head-to-head, the second stage surgery, defect in the mucoperiosteal flap next to the implant to be restored, and soft tissue punching technique. And the rules of the second surgery is bulking the keratinized or the connective tissue facially. We have already discussed this. Scalloping the keratinized tissue, limiting the incision to the keratinized tissue, preserving intact interproximal papilla, and using connective tissue grafts in conjunction to the second stage surgery. Bulking connective tissue graft, we have already seen how we can do it in the bulking in the pouching. I'm not going into detail of this. Scalloping is very, very important. This measure ensures tighter adaptation of the soft tissue around the implant. This is an article by Harrell in 2001, which says reducing the tendency for developing a dead space by scalloping and minimizing any possible soft tissue marginal distribution around the implant abutment. Now we know about the pouch procedures. I'm not going to detail. One video I want to show you the tissue enhancement around the implant, but here we are using a dermis material, not a connective tissue. It's the same principle. Okay, so we are creating a pouch here with a microblade, okay, or a microblade or a micro knife, and then this is alloderm. This is a dermis, commercially available dermis. So it reduces the second surgery. We don't need to have a secondary trauma to create. And now, just like the connective tissue graft, we have lassoed. Here also we are lassoing. This is the technique of lassoing. Okay. So we have grabbed this alloderm, and now we are lassoing inside. We are putting it in the pouch like the connective tissue. The only advantage of this technique is mostly that when we are placing it, we don't require to do any palatal surgery for harvesting connective tissue graft. So it saves the secondary surgery. Only disadvantage is a little bit expensive, and sometimes if it gets exposed, then the results are very poor. But for sub-epithelial connective tissue graft like situation like this pouch, this is almost inside the epithelial tissue. It doesn't pose any problem anymore. Okay. Now we will come to the classical roll technique. In this is a situation of roll technique. This is stage 2 roll technique. Okay, I have shown you one roll technique for simultaneous replacing implants. So first we will demethilize the prestal portion of the area, either with a bar or with a sharp instruments, and then we are going to raise, give the incision a little bit more palatally. You can see, and this incision is given a little bit so that you can infold this tissue. Okay, so we are now infolding the tissue which has been harvested from the palatal side, and now we are going to, because now this one will act as a connective tissue collar itself, and we are incising a little bit in the epithelium so that you can fold, otherwise it will bounce back. Okay, and now we are going for a lasso closure. Okay, now you can put this palatal tissue inside, and this implant is being uncovered in stage 2, and we are augmented the volume. Now you are lassoing this. Okay, so you are lassoing, you are taking the palatal tissue which is all, and it is acting like a connective tissue collar. The only difference is this is free. This is attached to the rest of the epithelium, and we have just given an epithelial incision to free it so that we can fold it inside and create a buccal volume. So you can see after folding and suturing how much buccal volume we are going to get. Okay, we have enhanced the buccal volume so much. Look at this buccal volume, such a big buccal volume because we have taken from the palatal side. Okay, and this is the volume we have got after 1 or 2 weeks. Okay, see the volume that we have got just by folding the tissues inside. 4 weeks. Now it's almost like the adjacent tooth. There is modified roll technique. I have already shown you during the incision that in modified roll technique you take not only the palatal pouch, palatal incision, but you take a collar of connective tissue from inside the palate. This is by Homlevon, and this is another premolar side. So buccal defect, we have done a split thickness pedicle flap and CT pedicle elevated in absent fat safe and given. So finishing today, what are the message we have? In dental implantology, the replacement of a missing tooth is the only one part of the treatment. Okay? We have to keep this, that we are trying to do replacement of the tooth, but this is only one part. The important aspect of the therapy consists of replacing the lost portion of the alveolar process, which we do by bone grafting, by GVR, and associated soft tissue. The soft tissue and the hard tissue, they go hand by hand, and unless they go hand by hand, it is very difficult to stabilize the long-term results of an implant placed. So it is very, very important that the soft tissue hard tissue harmony has to be there. If hard tissue is not there, we will be augmenting. But we have to remember simultaneously, if we don't have soft tissue, if we don't have conducive soft tissue, both in volume, in weight, as well as quality, we need to enhance the soft tissue, both in quality and quantity, to get long-term results which you can achieve. We can stabilize not only the bone, but the soft tissue is simultaneously very, very important. The re-establishment of a normal alveolar contour is a critical step in aesthetic success. And I would say one step further, that over-engineering is always a better procedure, because there is, when you have boosted the soft tissue and the hard tissue by biomaterials as well as natural soft tissue materials from some other sides, there will be some tendency of the body to reduce or shrink that in long term, maybe in a decade. So if we can over-engineer that, That is always preferable, because even after a decade, you will see, because we have solid evidences that the stability of the tissue is fantastic, but still we have evidences that there are 30 to 50% volume loss and weight loss in 1 decade. So if you can overcompensate that, probably we'll land up, even after placing an implant in aesthetic zone, even after a decade, which will be stabilized for another decade. And then if it is 20 years plus, our implants are really in the doorstep of success. So it is essential to understand the implant dentistry not without complication and difficulties. However, the long-term prognosis of the function and the aesthetics of the dental implants can be improved by correctly classifying alveolar ridge defects, so you need to know, by adhering to proper techniques for alveolar ridge and soft tissue augmentation simultaneously, and hand in hand by ensuring the most appropriate mode of implant placement in individual patients. With the sweeter notes, and still giving an emphasis on the soft tissue reaugmentation, I would say goodbye for the day and hope all you keep very well. Wish you all a very happy Ganesh Chaturthi and wish you health, life, smile, and wellness and prosperity. Thank you very much for your attention. Thank you very much.